Hi, I'm Jennifer Milner, here today with Dr. Linda Bluestein to talk through a presentation we originally put together with Dr. Bonnie Robson for the 2019 World Conference of the International Association of Dance Medicine and Science. The presentation is entitled Hypermobility Disorders in the Dancer, What the Dance Scientists Need to Know. We thought we would talk through it with you, keeping in mind that this is simply meant to be information. It is not meant to be medical advice and cannot take the place of speaking with a qualified health practitioner.
It's great.
Linda, shall we get started?
Yes, absolutely. It's so great to see you.
It's great to see you too.
So, as Jennifer said, this presentation was put together by all three of us. So I'm really excited to be able to share it with you today. So there are no disclosures, no conflict of interest, but we are going to discuss off-label treatments. And this is what we're going to cover generally about hypermobility disorders. And hypermobility and hypermobility disorders have been a subject of quite a bit of debate in the medical literature since 1972, when Professor Rodney Graham first published a paper on joint hypermobility, asset or liability. So this work has been really pivotal for a lot of people. And there's been a lot of other publications since then by Professor Graham and others disputing, is joint hypermobility in professional dancers, is it a sign of talent? Is it a vulnerability? Is it an asset? Is it a liability? And what I would state is that joint hypermobility itself is an asset. However, hypermobility disorders themselves are a liability. And what is a hypermobility disorder? This is an umbrella term that we used to describe hypermobility with symptoms. It's not just simply bendy joints. It may or may not indicate an underlying connective tissue disorder, and it's important to recognize the difference between joint instability and joint hypermobility. And joint hypermobility simply means a greater than average range of motion of the joint, and joint instability is when the joint is having difficulty maintaining proper position. Joint instability is probably even more important than joint hypermobility. However, it's more difficult to measure, so we often use joint hypermobility as a more common proxy. So hypermobility spectrum disorders were first introduced in 2017 as the classification that we would use to describe someone that has symptomatic joint hypermobility, but they don't have a more specific genetic diagnosis. It's important to distinguish between symptomatic and syndromic joint hypermobility, with symptomatic meaning that they have joint hypermobility and symptoms, and syndromic meaning that they have an underlying genetic disorder, genetic or connective tissue disorder. It's also important to know that patients that have symptomatic joint hypermobility may not have a genetic condition. And patients can have a genetic hypermobility condition or a genetic connective tissue disorder without having symptoms. So in 2017, the new classification was developed that looked at mutations in 19 different genes, and they came up with 13 different classes of Ehlers-Danlos syndromes, with the most common type being the hypermobile type. There's no genetic marker for the hypermobile type, which represents 80 to 90% of cases. There are two other types, the vascular type and the classical type, which are much more common than the other 10 types. So these four authors and their colleagues published 4 very important papers establishing the fact that hypermobility disorders are more prevalent amongst dancers, not just hypermobility itself. And if we think of hypermobility disorders occurring along a spectrum, with along the far left being hypermobility spectrum disorder, and on the far right being hypermobile Ehlers-Danlos syndrome, this is a conceptual way that we can look at these complex conditions. So if we start placing a few dancers along this continuum, and we think about where might they fall in terms of, are they in this bottom left area where they have symptomatic joint hypermobility but don't meet the criteria, the new stricter criteria for hypermobile EDS. Therefore, they would fall under the diagnosis of hypermobility spectrum disorder. So that would be on this far left side. Or are they going to fall more on the far right side, where they have much more symptoms, and they have symptoms that are suggestive of a connective tissue disorder and are therefore more likely to have hypermobile EDS? It's important to keep in mind that this is an approximation. This is not an absolute, and everyone needs to seek the care and advice of their own healthcare practitioners. So if we start with dancer 1, who is hypermobile and does get some injuries, but recovers normally, and we place that first dancer on the far left. Dancer 2 has the same hypermobility as dancer 1 and simple injury, but they also have joint pain, but nothing else. Dancer 3 has the same features as dancer 1 and 2, but in addition, this dancer also has some soft tissue injuries that are a little bit occurring more commonly, but they have normal skin. Dancer 4 has the same things, but also has additionally mild skin elasticity. Dancer 5 also has a family history and abnormal scarring. And dancer 6 has all of the features of dancers 1 through 5, but also joint subluxations, and that's where the joint comes out of proper alignment, but it's not a dislocation because the bones are still in contact with each other. So the question that was developed in 2017 when the consortium was looking at this, and they'd been studying this from 2012 to 2017, was where do you draw this line? Where do you draw the line between someone who has hypermobility spectrum disorder and someone who has hypermobile EDS? But I think thinking about this on a continuum is a very helpful concept. And there are 3 very important misconceptions to know about hypermobility. One is that joint hypermobility equals hypermobility syndrome. And this is simply not true. Lots of people have joint hypermobility, but they don't have symptoms. Therefore, they don't have a hypermobility syndrome. And the second misconception is that if you have a low Bluestein score, and we'll go into that in a little bit, is that they don't have joint hypermobility. The Bluestein score does not take into account the range of motion of the shoulders or the hips, for example. So someone can have joint hypermobility in joints that are not accounted for in the Bluestein score and yet be hypermobile. And the third common misconception is that the absence of joint hypermobility means that the person does not have a hereditary connective tissue disorder. As people age, they tend to be less hypermobile. And this is an extremely important concept because of the fact that oftentimes people become more symptomatic as they get older. So when should we suspect a hypermobility disorder? There's lots and lots of different symptoms that can be associated with hypermobility disorders. Many of these symptoms are more common in people with hypermobility disorders than in the general population. But it's important to note the ones that tend to be more specific. So I'm going to start with one that's less specific at the bottom of the screen. Sleep disorders and mood disorders. Sleep disorders and mood disorders are quite common in the general population. However, they are even more common in people with hypermobility disorders. So they're less useful than things like hyperalgesia and allodynia. Hyperalgesia and allodynia refer to when the nervous system is sensitized, and allodynia specifically refers to when things that are normally not painful are painful. So for example, clothing touching the skin or sheets touching your legs. Hyperalgesia refers to when things are normally a little bit painful, but they're instead a lot painful. So these are very important indicators that someone might be having nervous system abnormalities, which may or may not be due to a hypermobility disorder. Another really, really important feature is joint dislocations or subluxations. As we discussed earlier, if people have a hypermobility disorder, they may have joint instability. So the bones may come out of proper contact with each other. If the bones are no longer in contact with each other, that's a joint dislocation. If the bones are not in proper alignment, but they are in contact with each other, that's a joint subluxation. And then another important musculoskeletal feature of hypermobility disorders is persistent pain. People with hypermobility disorders can have microtrauma in the ligaments and the tendons due to overstretching and tears, and that can lead to pain. Other features that we might see include fatigue, gastrointestinal problems, and headache. All three of these are quite common in the general population, but these can be much more severe, more prevalent, more resistant to treatment in people with hypermobility disorders. The bottom two are much more specific to hypermobility disorders. Abnormal reactions to local anesthetic, which usually presents as resistance to local anesthetic or delayed onset, is more common in people with hypermobility disorders, as is abnormal scarring. It's also important to consider a couple of other conditions that we're not really going to have time to go into in any kind of detail, but you may or may not have heard of postural orthostatic tachycardia syndrome, which is a type of dysautonomia. And that's when the nervous system, the autonomic nervous system, is dysfunctional. This is something that occurs more commonly in people with hypermobility disorders. Another condition that occurs more commonly in people with hypermobility disorders is mast cell activation syndrome. This very complex disorder in and of itself refers to when the mast cells are less stable and they activate more easily, and mast cells contain hundreds of chemicals inside of them, which can have effects all throughout the body. So these conditions are important to be aware of because all of these conditions, hypermobile EDS, POTS, postural orthostatic tachycardia syndrome, and mast cell activation syndrome, have a lot of symptoms that can be in common. They have a tremendous amount of overlap in this middle area. And one very important thing in this paper that they did not mention, though, is anxiety. This is an important feature that can occur with all three of these conditions. We know that anxiety occurs much more commonly in people with connective tissue disorders and in people with hypermobility disorders. And it's also a very, very prominent feature in POTS. It's also a prominent feature in mast cell activation syndrome. So here's a picture of Jen with one of her dancers who has Marfan syndrome. And so anytime a dancer presents that has multiple signs and symptoms in multiple different bodily systems, we want to think, could this dancer potentially have a hypermobility disorder? And there's a saying, if you can't connect the issues, think connective tissues. So what are some of the criteria for systemic genetic connective tissue disorders? And this picture on the bottom is actually a patient that Jennifer and I have in common. And this patient has flexible pes planus. So their arches collapse when they stand up. So you can see that very well here in first position. And some of the other features that we see quite commonly with connective tissue disorders include a high narrow palate and dental crowding. We can see mild stretchy skin. We can see unexplained stretch marks and something called piezogenic papules of the heel. And you need to have somebody weight bearing in order to see this. And this is one of my patients in the upper right corner. We can also see atrophic scarring and something called Marfanoid signs of arachnodactyly. And this means that someone has really super long fingers and toes. And we also can look at the ratio of the arm span to height, and also the Steinberg and Walker signs, which refer to when you make a fist. Can you poke your thumb out from your fingers? And when you put your hand around your wrist, can you touch your fifth finger to your thumb? Whether a dancer is symptomatic or not, these are the things that I really want people to know about when they're working with a hypermobile dancer. It's extremely important to prioritize strengthening and control. Dancers love to stretch. And I know Jen deals with this a lot with her dancers. We want to avoid static stretching and overstretching, as that is particularly risky for these dancers. We want to be careful with overuse injuries and repetitive movements. Jen and I have worked with a dancer who attributes her shoulder injuries to doing finger turns again and again and again for doing the same piece of choreography. We want to consider potential modifications for risky choreography and seek care from appropriate healthcare professionals when indicated. So again, this is a dancer that Jennifer and I have both taken care of, beautiful young pre-professional dancer who unfortunately is no longer dancing due to her condition. Fortunately though, she was under the care of Jennifer Milner, who said, I'm wondering if maybe there's something more going on here than just you're having some bendy joints. Maybe you should get a medical evaluation, which helped lead her to getting more appropriate care as she does have a diagnosis of hypermobile Ehlers-Danlos syndrome. Again, this is the most common type of EDS. The genetic marker has not yet been identified. And this is a checklist that you can take to, where's my cursor? There it is. So this is a checklist that you can take to a doctor's appointment and ask them, do you think any of this could potentially apply to me? You can print this off and take it in for your appointment. And in the upper right corner, it shows how to properly do a Beighton score. And the Beighton score has to do with several maneuvers. Can you touch your thumb to your forearm, which I used to be able to do, but not anymore? Can you bend back your fifth finger more than 90 degrees? How hypermobile are your elbows and knees? And can you touch your palms to the floor with your legs, with your feet together and your legs straight? But again, it's important to note that number one, that point system is biased towards the upper extremities, and number two, most dancers can touch their palms to the floor because we train for that. So while this scoring system is used in many cases for establishing the diagnosis, it's definitely not a perfect system. Vascular Ehlers-Danlos syndrome can look like this. These are two sisters who are very athletic, and the one on the right had many additional features of vascular Ehlers-Danlos syndrome. She was diagnosed with this condition and sadly passed away from this disorder at age 15. So it is very important to be aware of these disorders because although vascular Ehlers-Danlos syndrome is actually quite rare, we want to make sure we don't miss any of these cases. Hormones can also play a very important role. So in this figure at the bottom, we can see that at the time of puberty, so the dashed line is males and the solid line is females. And at the time of puberty, which is right here, joint laxity goes up in females and it goes down in males. And we know that pregnancy, breastfeeding, menarche, menstrual cycles can greatly influence not only joint laxity, but also clumsiness and proprioceptive difficulties. And sometimes patients can benefit from having hormonal manipulation. Fear is an extremely important component of the pain response. So we want to make sure that we do everything we possibly can to minimize fear. When we become injured and we have a pain experience, if we have a lot of fear, then we are going to be over on this left side of this figure. If we are able to minimize the fear, then we can shift from the left over to the right, and we can have a greater chance of having meaningful recovery. The treatment model that I've been using is a multifactorial one, and we'll talk briefly about each one of these components. So movement is an extremely important component. We want dancers and everyone moving as much as they possibly can. And Jennifer uses some extremely creative exercises with her dancers in order to get them moving with the most functional movement pattern possible. And we want to keep in mind sleeping posture, sitting posture, standing posture. We want to maximize joint stabilization, and we want to retrain the nervous system so that we can be moving in the proper way and also improving proprioception. Okay, we even got sound here. So this is Jennifer working with this is the same dancer that I had showed you earlier who has hypermobile Ehlers-Danlos syndrome.
And side. Nice. And close. Dégagé. Fondu. Plie. Dégagé. Stretch it good. Don't control from the back. And to the back. Stretch and reach. And back in. Drop your right arm a little bit, but keep that. Yeah. And to the side. That looks beautiful. And close. Switch your arms and just do the fondu. And dégagé. Watch your right elbow. Fondu.
I love that. Switching the arms,
Nice.
but not the legs.
And stretch. Well, the point is to challenge the body to stabilize.
Right.
In different ways, right? So it's not even as much about strengthening the dégagé or anything as it is about the body learning to respond to the feedback.
Right.
That's going on while they're doing the fondu.
Right. That's such a key thing that you're doing there, Jen. By switching up the movement, you are less likely to fall back on dysfunctional movement patterns because it's something that's new to the body.
Right.
Is what I'm thinking, that the body is already going, okay, wait, what is this? And as dancers, we're so used to doing a lot of the same things multiple times. And so it's easy to do them the same old bad way.
Mm-hmm.
So I love
that. And that's the key is not letting the body make assumptions as it's moving. Is to challenge it with new things, not necessarily fancy new. It has to be new and amazing and different every time. It's just different ways to make the body not fall into habits.
I love that. Education is such a hugely important thing. The more we understand how pain processing works, how the body works, the more we are able to use our body and maintain function. As an anesthesiologist, I generated these cards for my patients and other individuals in the event that they would be undergoing anesthesia or surgery, because most healthcare professionals are really not very aware of these complex conditions. And nutrition is extremely important. We need to keep in mind that our body is constantly growing new cells, and we need to give our body the proper nutrients in order to do that in a healthy way. And we also want to make sure that we're doing everything that we can to minimize chronic inflammation. So while there is no one size fits all, there are some general guidelines that are pretty true for everyone. For example, sugar. There's nobody for which sugar is a good thing. So anytime we can minimize sugar, that's beneficial. A really important thing to know about is gluten. So people that have hypermobility disorders are more likely to be sensitive to gluten than the general population, even if they test negative on a celiac test. So sometimes by eliminating or at least reducing gluten in the diet, they can make some meaningful improvements. Other things that a person may be sensitive to include dairy, red meat, and artificial sweeteners. And we especially want to avoid preservatives and pre-prepared foods. And an easy way to think of this is whenever possible, you want to eat from farms and not factories. Sleep is extremely important, especially for your immune system and for proper functioning of your body and for reducing chronic inflammation. So the question is, do you awaken feeling refreshed? Do you feel, like you're getting enough sleep? It's hard for dancers because oftentimes they have performances and classes late in the evening, but ideally we're going to bed before 10 o'clock or so, because the hours of sleep that we get before midnight can be the most beneficial. And ideally we have electronic devices in a separate room and avoid screens before bed. The circadian rhythm is extremely important. So ideally we're sleeping when it's dark and we're awake when it's light out. And this can help significantly with mood disorders. Sometimes dysautonomia or dysfunctional autonomic nervous system function can also be a contributing factor for poor sleep. And we also want to take into consideration the psychosocial implications of hypermobility disorders. We want to make sure to address and treat mood conditions, mood disorders, and cognition problems. It's not uncommon for people to present with brain fog, anxiety, depression, catastrophization. And catastrophization is when you always think that the worst is going to happen. And so when somebody is experiencing that, it's very important that we support them as much as possible and help to question those beliefs. There's a couple of programs I want people to be aware of that can be extremely effective in these situations. So one is cognitive behavioral therapy. I think most people are probably aware of that. Another one is EMDR, eye movement desensitization retraining. And that can be extremely effective if people have post-traumatic stress disorder or some kind of trauma in their history. And the other one is DNRS, that is dynamic neural retraining system. And that can be extremely helpful as well. There are a number of modalities that can be very helpful. And it's important to keep in mind that no one of these things is likely to produce 100% resolution of pain. In general, we might get 10% from one thing, 10% from another thing, and eventually that adds up to some meaningful gains. And there are a number of different medications that can be used for hypermobility disorders. These are the ones that I've most commonly prescribed in my practice. There's a number of supplements that are also important, and it's important to keep in mind with supplements that these are medications. They're just not regulated by the FDA at the same level that medications are. So it's very important to keep in mind that if we're looking for biologic effects from these things, we can also have biologic side effects. So all of these need to be taken in a certain way. They all have indications, contraindications, etc. Always work with your healthcare professional. There's a few precautions that are important to be aware of. One is to avoid fluoroquinolone antibiotics whenever possible. And these are ciprofloxacin, which goes by the abbreviated name of Cipro, and levofloxacin, which goes by Levaquin as the trade name, because these can weaken connective tissue and they can increase the risk of tendon rupture, increase things like tendinopathies. It's also important to avoid or minimize steroid injections because these can weaken connective tissue and can increase the risk of tendon rupture. And although in the short term that having a steroid injection with local anesthetic will make the pain feel significantly better, in the long term, a year out, 2 years out, the studies show that there's really no benefit. We also want to be careful with procedures and surgery because the outcome may be different than what would be expected from someone that does not have a hypermobility disorder. We also might experience slow healing. And oftentimes the procedure or surgery doesn't address the underlying problem. Whenever possible, we want to avoid opioids because of the risk of substance use disorder. They can also cause opioid-induced hyperalgesia, which is where opioids make the nervous system more sensitive to pain, like we talked about earlier. We talked about hyperalgesia earlier. And also opioids can activate mast cells and cause mast cell degranulation. And we talked about that earlier. Patients who have hypermobility disorders are at increased risk of mast cell activation disorders. So we want to avoid things that activate those mast cells. And we want to stop doing party or circus tricks. I ask patients usually to show me those tricks. I videotape them doing those tricks, and then I ask them to not do them anymore. So in summary, hypermobility disorders are actually quite common in people who are having pain and other symptoms, and especially in dancers, who we know are more hypermobile than the general population. It's very important to recognize these disorders because they can have a significant impact on treatment strategies. Certain strategies will be less desirable and other strategies will be more desirable. And we need a lot more research in this area in order to determine what the optimal treatment approaches are. These are some areas for future research, and I encourage anyone who is interested in research to please contact me, contact Jennifer. Very interested in collaborating with other professionals. And these are some influential papers. And this is the panel, this is the team. I'm so grateful to both Dr. Robson and to Jennifer Milner for their outstanding work on this. This is the checklist that I had mentioned earlier, and it can be found at ehlersdanlos.com. And here's some other resources. Okay.
Excellent. It was so great to go back through that again. And it's not by any means definitive. It's certainly not exhaustive. We could sit and talk about each one of those slides for an hour.
Right, right, easily.
and go off on the details of it. But hopefully it's a general sort of overview of things to be aware of with dancers, warning signs to look for, possible methods to explore for ways to help with treatment, and in general, just trying to raise the awareness level for dance scientists, dance teachers, and dance doctors as well as dancers themselves, to see those things and go, oh, hey, that sounds like me. Oh, that sounds familiar. Oh, I had that. So hopefully in sharing this, it will give you guys some place to start on your own path to kind of figuring out what's going on with you and what your next steps will be.
Yes, absolutely. And Jennifer, can you share more? You've been working with hypermobile dancers for a long time. So you know lots and lots and lots about working with hypermobile dancers. For people that want to dig deeper and would like more information, can you let them know where they could find more information about what you're doing?
So my website is simply jennifer-milner.com, JENNIFER-MILNER.com. And my Instagram is at jennifer.milner, Jennifer.Milner. You can reach out to me either of those places. I love questions. I love talking about them, and I love problem solving with people. So you can reach out to me there. And Linda, where can I find you?
Hypermobility MD. So hypermobilitymd.com. And that's also where I am on Facebook, Instagram, Twitter, LinkedIn, a few different places. So, and I love collaborating with people. And yes, you and I could just talk for, I don't know, probably 20
hours.
Yeah. I was going to say 24 hours straight, but probably much longer than that.
Probably.
Yeah.
Well, thanks so much for watching. We hope that you got something valuable out of it, and we will see you next time.
Thanks.